Welcome to our channel MBBS Made Easy. Today we are going to discuss about the topic botulism. So, what is botulism? Botulism is a disease wherein you will see descending paralysis, or which is a flaccid type of paralysis. Now, we will learn about the 6 points in this. First thing, what is the organism which is causing? Second, what is the pathogenesis? What are the clinical features? Number 3. Number 4 goes for the investigations. Number 5 is the treatment. And at last, we'll have a clinical question. First, organism. The organism which is causing botulism is the Clostridium botulinum, which is a gram-positive bacteria, and it is an anaerobe. So, the bacteria forms subterminal spores. What do you mean by subterminal spores? Here you see, here is the spore, and this is the midpoint, and this is the end called terminal. If the bacteria is just in between the midpoint and the terminal and close to the terminal, this is called subterminal. If you see in microscope, it forms these type of subterminal spores. I'll show you it in another diagram. Now, pathogenesis. The organism is a bacteria. So, the spore which is formed will germinate and form a toxin, which is called endotoxin, the botulinum toxin. What does this botulinum toxin do? First of all, the toxin enters the body of a person, and it blocks or inhibits the acetylcholine at the neuromuscular junction. Here we see a neuron, here we see a muscle, and this is called the synapse, and this is called neuromuscular junction. When acetylcholine is being released by the neuron and it is traveling in the synapse, and here are the receptors on the muscle where the acetylcholine will show its action, from where the signal is taken and the muscle function is being done. But when the acetylcholine is inhibited, release is inhibited in this neuromuscular junction, there is no response from the muscle, which is causing the paralysis of the muscle, which is nothing but the flaccid paralysis. Now we will see what are the types. There are 3 types of infection. Actually, broadly classified, it is 2: foodborne and wound. And in foodborne, it is adult type and infant type. In adult, we will see the preformed toxin. That is, the toxin is already present in the food which is being ingested by the adult. That is called the preformed toxin, which is generally seen in the canned foods. In infants, there is a practice that there are prelacteal feeds are being given where the honey is given to the infant. And when the honey is given, the honey contains this organism but not toxin. When this organism will enter into the infant, it causes the release of the toxin, which causes the paralysis. And the second type is wound, where the organism enters the body through the wound site. These are the types. Now we'll come to the clinical features. See, if a person is being infected and will come to OPD, you have to see the clinical features of the person first. There is a systemic descending paralysis, which is a characteristic of this disease. Descending paralysis is the paralysis is occurring from the top to bottom. So, first it starts with the extraocular muscles. When the extraocular muscles are paralyzed, what you can see is the ptosis, diplopia, and blurred vision. These are the symptoms. Then the pharynx is getting involved. You know, when pharynx is involved, what is the problem? Dysphagia. The person will have problem in ingestion of the food. That is swallowing. Next, larynx and respiratory muscles. When these are involved, the person will suffer with breathlessness. And if respiratory muscles are involved, ultimately leading to respiratory failure because of respiratory paralysis, which leads to the death of the person. And before the death, if the respiratory muscles are involved, and later the generalized flaccid paralysis is seen. Here is an interesting point that the person is conscious and alert. Even he's having paralysis, flaccid paralysis, he's conscious and he's alert. And fever is generally not seen. If this is a scenario, if a person has ingested the bacteria or a toxin, if it is inside the gastrointestinal tract. Now, if the toxin is from intestine, that is the ingested bacteria, and the toxin is released, then the origin is intestinal in origin. In that case, you can see nausea, vomiting and diarrhea, which are the common GIT symptoms. Now, due to which, what happens? Nausea, vomiting and diarrhea is seen, and sometimes you can even see paralytic ileus. This is because the intestinal muscle paralysis can also occur, which causes paralytic ileus. Here are the signs and symptoms of botulism. If you wanted to take a screenshot, you can take. See? Here is the microscopic view. Can you see that subterminal spores are here? This is what I was saying. Okay. Now we will go for the investigations and treatment part. Investigations. You have seen the clinical features of the patient. Now what happens is that the clinical features I'm giving you a clinical scenario here. Just try to answer or analyze yourselves. See, a person came to the OPD with the symptoms of symmetric descending paralysis. Here the major important point is that the paralysis is symmetric. See, if ptosis is seen in the right eye, it is also seen in the left eye. It is not like, see, right eye is having ptosis and left eye is normal, it's functioning normally. No, both the eyes are having ptosis. Means the paralysis is symmetrical bilaterally. So the person came with descending flaccid paralysis, which is symmetric, and there are no sensory defects, and the person is mentally intact. That's what I said, conscious and alert. And the person is afebrile. He is not having fever. What would you suspect here? As I said you before, symmetric descending flaccid paralysis and conscious, alert, afebrile. These are the situation where you have to suspect the person might have had botulism. Now what you'll do is that you are thinking it, so you have to confirm it for giving the treatment, appropriate treatment. What you'll go for is an investigation. Now what you'll do is that a toxin is there. You have to find out or identify the toxin. The toxin is seen in, see, preformed toxin I said. So it is seen in the food particles, so suspected food. Once the person has ingested food or he is having which is contaminated with the bacteria or toxin, the toxin will be released in his system. So in serum you will check it, and it is entering the GI tract obviously. So what you have to see is that vomitus, stool and gastric aspirate. In these places you have to identify the toxin, and later you have to do the culture of the suspect, or media how to grow this bacteria in the suspected food and wound culture, where you can identify the Clostridium bacteria, which suggests of botulism. If it is found in wound, it is called wound botulism. Now treatment. What kind of treatment you are going to give? See, it is a toxin. The problem is majorly because of toxin, just not the bacterial presence. So first you have to give the antidote for the toxin. What is the antidote? Antitoxin. That is nothing but botulinum antitoxin should be given, that to IV, as soon as possible, because the person should not land up in respiratory paralysis, so you have to give it fast. Now you have given the antitoxin. Can you guys think about another condition where you can see that we are giving antitoxin first? The disease starts with D. Organism D. It is diphtheria. Even in diphtheria, you'll give antitoxin first because the toxin is the problem. Okay? Now, after giving toxin, what do you do? See, you gave the toxin, but bacteria is still present, so how to decrease the bacterial load? What you'll do is that you'll give antibiotics. See, if a person is having wound and through which the bacteria has entered, you'll give antibiotics at that site or systemic. You'll give penicillin G or metronidazole, which are choice for this particular infection. Next, you have to assess for the respiratory improvement or monitor the respiratory condition of the patient, because the major cause of concern of death is the respiratory paralysis. So, you have to check the person will not land up in respiratory failure. So, you have to monitor. If you feel that the patient is developing respiratory failure, you have to go for endotracheal intubation or mechanical ventilation. If you think that the mechanical ventilation is needed for a long time, then what you'll do? See, endotracheal intubation you can't do for a long time, or mechanical ventilation, so you have to do tracheostomy. Thank you.